Hi, my name's Tori and I wish I knew more about blood products.
Hi, my name's Letitia. I wish I knew more about taking care of myself when starting shift work.
Hi, my name is Lydia. I wish I would know more about how to work as in a team and solve conflict.
Hello, welcome to 5 Things, the nursing podcast from the Royal Brisbane and Women's Hospital. My name is Liz Crowe.
I'm Jesse Spur, and this is a podcast by, for, and with the amazing nurses and health professionals in our corner of the world. We hope to connect with a global community as we move from surviving to thriving. Welcome to 5 Things.
Hello, my name is Liz Crowe.
And I'm Jesse Spur.
And today we're going to do something different. Jesse and I are really going to have a conversation about debunking all the debriefing myths that are happening out there in the world, a passion for both of us. And the reason we think this is so important at the moment is because with rising acuity, complexity, a junior workforce, Jesse and I know that debriefing to learn is really pivotal. And at the moment, all the myths around debriefing continue to stop that from happening.
Yeah, absolutely. So we're going to dive into this, but first setting a little bit of a foundation of what are we talking about when we're talking about debriefing in relation to debriefing learning in a clinical setting?
It's a great question because people watch Married at First Sight and debrief after it. Someone, goes on a terrible Tinder date and they debrief. And so we don't have this common definition across the world. But essentially, when we're talking about debriefing to learn in a clinical setting, what we're talking about is a deliberate and intentional stopping that is facilitated by an individual in a multidisciplinary team environment normally, where we're going to look about reflecting, learning, looking about what we're really proud of, what went really well, what we'd like to replicate again in the future. What were the kind of points or the rubs, as you like to say, the things that if we had the chance, this clinical situation, this same patient again in an hour's time, that we'd like to do something different, and what were the points of learning? And the other big, really important part of a debrief is sharing the story or getting the kind of facts right so that we're all on the same, what we call shared mental model, so that everybody actually is thinking the same thing.
That sounds so great. Why aren't we doing it?
That's what you and I don't understand. So today we're going to debunk the debriefing myths so that people at least can know what's fact and what's fiction.
Awesome. So the format we're going to do is not so much an interview as a chat. So we're going to queue up each of our 5 points and then just break them down per se. We do have to air, if it hasn't come through already, that we are incredibly pro-debrief biased here, both from experience and Liz also from a large volume of years of experience, but also academic research work and living in this space in her PhD. So she's very well qualified for this. I'm an enthusiast, so let's rock and roll.
I don't think that's entirely true, but let's rock and roll anyway.
Alrighty, so one of the pervasive myths that gets thrown up first and foremost all the time is debriefs can cause harm. Where did that come from?
This is like such a point of frustration for me. So what happened was there was a Cochrane review by Rose and colleagues, first of all in 1996 and then again in 2010, where they looked at 15 articles where they had forced people, patients mainly, into a one-on-one, not a group context, but a one-on-one psychological debrief. And the populations they used were unethical, in my humble opinion. They were women who'd had stillbirths. They were people who'd been involved in assaults and motor vehicle accidents. There were people who had acute traumatic burns and were still in hospital having burns treatment. And these people were kind of, coerced. It's hard to know how they were involved in this because 8 of the 15 papers were never published, which normally that means you can't be involved in a Cochrane, but these were. And out of that paper, so doing something completely opposed, different to what we do, nothing that we encourage, debriefing just got a really bad reputation that it has never been able to live down.
That's a great breakdown because as a enthusiast or a pro debriefer, I've been aware of that Cochrane review and how flawed it was, but not really had the depth of exploration on that. I've always kind of equated it to being the vaccines causing autism publication from the Lancet that was withdrawn subsequently, but then gets its hooks in to this kind of pop culture discussion or popular beliefs around it.
And that's exactly right. And it makes no sense to me because people have already done the work. They've had the exposure. You know, the worst thing out of all the horrific, terrible, traumatic things that I've seen across the course of my career, the number one thing that really causes harm to clinicians is, could I have done better? If this had been a different team or there had been someone else in my role, could we have had a different outcome? That's the thing that keeps you up at night. You know, like we do see some pretty horrible things, but we're not advocating that that's why you debrief. We're talking about debriefing to learn. So it is the polar opposite of what all the Cochrane was about. I agree with the Cochrane. I don't think anyone should ever be forced to participate in a debrief. It should be absolutely voluntary and it should not have its foundations on reducing or preventing psychological morbidity because we don't have a baseline. We're not actually going to test people in the future. And we don't test people before they start a shift. We're not psychologically testing people before they start a shift. And often, you know, that's where stuff's happening.
Before we move on, I'm keen to tug on the thread of that, the thing that causes the most kind of pervasive ongoing niggle or harm. Was this from your PhD work that you found that kind of lack of ability to understand, could we have done something better? Is that, or am I putting words in your mouth there a bit?
You kind of are. So just to clarify, my PhD didn't focus on debriefing, but what people kept saying was, we need to debrief to learn. Like what's really bothered me, I guess one of the big things that came out of my PhD is that everybody who talked about the worst day in their career always attributed it in the first 3 to 5 years of their working career. Now, that's just not possible, particularly like I interviewed people who'd been working in critical care for, 36 years. I know because I've worked beside them that we've seen pretty horrible things, but it's in that first 3 to 5 years, it's so overwhelming. And, the distress, it's not like you get to a point in your career where you think, oh, that didn't hurt. That doesn't bother me. That's not what's reflecting me. But I just don't think you're so overwhelmed by it as you are in the early days of your career.
And don't have the tools or experience to kind of even partially answer that question of could I have done something better or differently in that, which I think over time and experience, I can answer that question to myself reasonably accurately and comfortably now, 15 years plus into a critical care and emergency career, but I couldn't have in the first 3 years. And I guess the answer to that may be debriefing in a group.
Well, it's not only talking to yourself. Like I think, being able to actually talk to an expert about it, like someone who actually isn't attaching emotion to it, but is like, what are the facts? What are the actual facts about what happened? And, that is getting on that same shared mental model. And of the hundreds and hundreds of debriefs that I have been involved clinically across the course of my career, it never ceases to amaze me how someone's memory of what happened and what are the facts are so different, even 2 minutes after it's finished.
And I guess this is putting you on the spot, but subjectively or anecdotally, have you heard back from anyone that was really distressed because of or attributed to having been involved in a debrief?
Okay, I need to think about this. Yes and no. So when people have been involved in debriefs and then later report that was a horrible event and I'm never going to be involved in a debrief, it's usually because someone, either who facilitated it or was in the group, pointed fingers, made accusations, or someone's wandered in and said, oh, if I'd been involved in that, I would have given this drug at this point in time. it's usually around the clinical facts or fiction that come out, or because people feel blamed. And none of those things are debriefing to learn. And that's why you've got to be careful when you're setting up a debrief to learn. You want to make sure that's the intention, to learn, not to judge, not to say what you would have done better, to know that everyone who'd been involved was giving everything that they had, all the tools, all the skills, as something has unfolded. Because once we know how something ends, it's very easy to say, I woulda, I coulda, I shoulda, But when you're in the moment, that you can't do that. You're bringing the best to you. But if you stop and learn, if there was an error or if there was something that could have been done better, then you take that forward into your career. If you never discuss it, you could actually make that same mistake again.
Yeah. So we're going to move on from point one, but I think it lays the foundations for some of the extra other myths that spin off that we're going to actually circle back to some of those key points. We're not saying that poorly directed communication can't cause harm.
Because it can.
We're saying that debriefing to learn with the intent and the structure and the rigor about a process and shared goals about that is unlikely to cause harm.
That's right. And look, if I was going to run a debrief, and I have, and I think this is all becoming very political and it's teams pointing fingers, I don't do it. That can harm. But that's not the process of debriefing that's harming. That's people with an intention to harm can harm. They can do it very successfully. All right, let's move on. You can tell we're a bit passionate about this. So, Jessie, point number 2. Debriefing can only happen after a critical event. True or false?
I think true and false. At the moment, it tends to be swayed that way. And that's why some of the murkiness around the labeling of it, of critical incident debriefing, critical event, clinical event debriefing, all of those things. The evidence around it and the papers published even in an emergency and critical care context really point towards debriefing the mundane, having predetermined triggers to actually debrief to learn from events that maybe went well. Debrief the process rather than the outcome. So at the moment, there is still this bent. I've seen this after facilitating debriefs post resuscitations in medical emergency calls on the wards. One that sticks to mind was there ended up being 13 participants that hung around, or professionals that were involved in this resuscitation, that went for about an hour on a medical ward, hung around after their shift finished because they really valued the debrief. And there were people there that one nurse told me she'd worked in medical ward for 17 years and had never been involved in a debrief. And had never experienced anything like that. This was completely a debrief to learn. There was psychological distress in that the outcome wasn't good, but there was a lot of learning from the process and just perspective taking on every member's behalf, right from an intensivist through to a student nurse and a wards person. So I think it's requalifying and broadening the perspective about it. And really blowing up that perspective that it is a critical event. For me, a resus isn't a critical event. It may be on a ward, but there is equivalence in your work that we can predetermine and build in as those pre-identified triggers that empower us to get together for a debrief.
I, strongly advocate, as you say, starting with the debrief to that's something that's mundane. Debriefing can absolutely and should happen after brilliant work, because sometimes we need to understand what made us excellent and how do we replicate that if we don't stop and work out, actually, this wasn't a fluke. This was expertise, or this was this style of leadership, or it was this level of communication, or it was involving this person at this critical point in time.
Yeah. And also sometimes just arriving at the fact that there was absolutely nothing that could have been done differently from a process when something didn't go as hoped or expected.
Yeah, absolutely. Absolutely.
So we'll keep sliding along to number 3. Debriefs should be psychologically based. Oh, I can feel you winding up here.
Debriefs should not be primarily psychologically based, because I was thinking about this driving today. Think of your favourite sporting team, right? Even if you're not, you're not into sport at all, if you've ever watched any level of sport on the TV or live, every time that team or that person stops, pauses, has a break, the person who runs the water on, they're debriefing, they're catching up, they're giving instruction. They're like, this is what's happening, this is how we could do it better, this is the learnings, this is whatever, right? Imagine if you're a famous sports person, you belong to a team, and you lose a game, and the only thing the coach wants to talk to you about is how you're feeling. Like it'd never happen. Debriefing came out of World War II when the military started debriefing. All their teams came back, not about, oh, how are you feeling about that? They were in a war. Like no one wanted to be there. It was horrific, but it was like, what are the learnings? What could we do better? Like where were the enemy? Like what were the pros? You know, that's exactly what it should be about. So it makes no sense that you grind that just into a psychological kind of frame. Michaela Colby wrote a really brilliant paper in 2021, which I was like, oh my God, that's so simple. Why didn't I think of that? Where she was saying in clinical scenarios in a hospital, there are 3 reasons people debrief. Number 1 is to learn, and that should be our primary intention and driver. Number 2, people do it to try and prevent psychological morbidity, and there has never been any evidence for that, and nobody recommends it, including that paper. And number 3 is recognizing that sometimes we may just need to debrief to manage the big emotions, the big feelings. So that's where either good or bad, you know, things went as well as they possibly could have clinically, but recognizing that maybe the learnings are really about this was really awful, this was hard, and debriefing gives us an intention to stop, reflect, be together in a shared experience with a same shared mental model.
I really like a pick-up and sort of reductionist catchphrase here and there, you may have noticed.
Never.
But for me, that really is about this concept of the debrief is for psychological diffusion, not diffusion. We're not trying to moderate an emotional valence or state. We're trying to diffuse that and normalize it.
And a big part of those when you do those debriefs to manage, which I never ever do with without operational and clinically unpacking things, because I think it's important to get everyone on the same page. But sometimes it's just like, wow, what did we experience, see, feel? You know, like, and for confidentiality, because we don't want to harm our families, our friends, our flatmates, our partners, our kids, whatever, you've got to put it somewhere safe. Number 4, there is a myth, Jessie, that you can't lead a debrief if you were involved in the event.
Cool. Well, then give me someone to come in there, swoop in and facilitate that conversation effectively when they're needed is my answer to that. That's a bit of a pithy answer, but pretty much every clinical debrief that I've facilitated has been one that I've had at least a partial clinical skin in the game, so to speak. Some from being as complex as an hour-long resus team leader working with an ICU reg and medical registrar and ending up running the resus myself with their medical orders and input, through to some where I've come in at the latter stages of a resuscitation in an emergency department when I was nurse educator to help in that last critical parts of it before the resuscitation attempt was stopped. My answer to that is a kind of a flipping of it, is going, you need a fair degree of experience and training in debriefing to manage the cognitive load of debriefing. And then if you pile that in with your own emotional responses, so you need to be able to self-monitor, would be one of my take-homes from that. Self-monitor your emotions and self-monitor your dialogue and have enough bandwidth to hear and process and create space for what other people's experiences were. That is complex. I'll acknowledge that. But as a hard fact saying that you shouldn't facilitate or lead a debrief, I guess some of this is in the sticking of the words. I would never say I lead a debrief. in those situations. I'd say I'm providing structure to a conversation that we've all got skin in the game from. And I am transparent when I set that up of going, I've had my experience of this. I'm not leading this. I'm just going to give us a structure to work with. And we're going to aim to have this done in X amount of time. So create some predictability and a sense of safety through showing that there's a structure and there's some rules to this game. That's about it.
I think there's such a risk in inviting a third party in, even if they are an absolute expert in the field, because once we know how something ends, we can go back and go, at this point, maybe if this had done, or at this point, that's so unhelpful. The person is facilitating, guiding the conversation. The person should not be pontificating. The person should not be judging. The person should not be could there be exceptions to this? Sure. Maybe this is all resuscitation, which we are saying debriefing should not be about that. But just say you do lead a resuscitation that goes on for 2.5 hours and your brain feels a bit fried, everyone who's involved. There's usually someone who has been involved but is on the periphery, whether it's the team leader, whether it's, someone that can help pull the group together and facilitate. But to say as a hard and fast rule, if you're involved, you can't lead, I think is an absolute myth. And I think it introduces a whole element of risk that's unnecessary.
Yeah, and we're not saying that there shouldn't. I guess one of the antidotes to this is that there is broader training to create a greater density of people who are capable and trained and have either the repertoire, the communication skills, or a tool to guide their practice in facilitating a debrief. That is a bit of an antidote to the necessity of having someone that was involved in it. But I have seen and been involved as a participant within a debrief. I hate the term, but as a clinician who's being in a debriefing conversation where I wasn't leading it, and there was someone that came in to facilitate that debrief to learn that was on the very hot back of actually experiencing the clinical situation, and they knew nothing about it. The issue with that is where that debriefer sought their sources of information from. And what my observation as a nurse is it ended up being a very medically biased debrief because the natural tendency was to go to the most senior doctor that was there and the facilitator of the debrief, asking them for the facts of what happened. And that actually played into the power and hierarchy that already exists in that group that we're trying to actually dismantle a little bit when we're facilitating a debrief.
All right. I'm going to ask you number 5 as well, because you're the nurse in the room. No time to debrief. We know that that's one of the greatest barriers to debriefing actually happening. Is it a myth?
It is, but we do end up doing it in some way. It leaks out. So I think there's a couple of factors to this. Is work is really busy. We find funny little pockets of time to do other stuff, and that's a lot of that's just out of either tradition or workflows or just normal task orientation. My observation is particularly when something has not gone as planned, that there's an ongoing niggling inefficiency that spins off that if we don't stop for 10 minutes stopped to have a chat, can avoid 2 weeks of turmoil and bubbling up conversations and vicarious trauma through the rest of the unit. These little myths and I guess rumors starting to slip around about who said what or what was done, and it can and observationally, I would say it can even get to a point where it can impact on people taking sick leave.
We talked previously about can debriefing harm? The very few times that I've seen debriefings done harm, it's because someone in the group or the facilitator has said things that have been extremely unhelpful. But I can tell you the amount of times I've seen harm done because no one will stop and debrief and face a big, not even an elephant, the big demon in the room, the concerns, the rumor mongering. You're right. People say we don't have time, but then you see, where's so-and-so? Oh, no, they're crying in the toilet. Where's this person? the registrar had to go out and have a coffee because they were still so heightened. To actually just formally stop, say this is important enough for us to reflect, to think on, to come together as a group, can save weeks to months of, uncertainty, poor self-esteem, potentially sick leave.
I've had an example where a friend who was also a recent, a novice in emergency department rang me and asked about, is it normal to not debrief after a case like this? And talked to me a bit about it. I wasn't working there. This was 2 weeks after. And to the point where she was going, if it's normal that we don't talk about this sort of stuff, this sort of an event after it happens, I don't know if I can keep doing this. I don't know if it's the right work for me. Like, that would have been mitigated by a debrief after it. There was more detail to that, where there was sort of splintered and factional debriefing, I'd call it, by professional groups about that particular case. But these things happen. This kind of goes to that other point I make, is that the debriefs kind of end up happening in this haphazard way anyway, because we're just fairly simple animals after all said and done, and we try and make sense of a process or an outcome that doesn't intuitively make sense to us. And how do we do that? We get together with someone and talk about it and end up trying to come up with some shared reality of what happened, like a socially generated contract about what the facts are. And I don't know if this phrase is mine. I've said it a few times. It's been attributed to me by
I
other
constantly
people
tell everyone around the world that you said it.
Well, thanks, but I won't. I think it's a really useful phrase. Is if we don't debrief, we will tea brief. And what I mean by that is the tea room chat that starts to happen. And that can happen minutes, hours, days, weeks after it. When it's happening weeks after it, that's probably the biggest pointer to me, that there should have been fundamentally time made to debrief that, because this has become persistent, pervasive by that state. So meeting diagnostic criteria for psychological illness, even persistent, pervasive across settings, this has been talked about. So that kind of tips back to me going, it is complex. There can sometimes not be time to do the perfect debrief. So what I would spin back to that is, I really got to the point in my practice of going, there's a minimal data set debrief that has to happen, which is a check-in together with everyone, just going, whoa, something that was something that's just happened, particularly if it's something serious and impactful. That's something that's just happened. How is everyone doing? Just that general sort of emotional diffusion at the start, and then going, what do we know? What were the absolute non-negotiable facts out of that, the objective facts, so that we don't get left kind of conflating, and this is your one that you might have co-opted, is this feelings or is this facts?
Yeah.
We don't end up essentially attributing fact to what is just actually feeling.
Yeah. And look, I just think that whole thing, debrief or tea brief or sick leave, that's it's a reality. And I say to people, we can't afford not to, because if people are in their own heads, then everything that they're doing moving forward in that shift or in future shifts can be impacted by that event. And that's far more harmful than taking 8 minutes out and saying, we're just going to stop for a minute and work out what was fact and what was fiction and what we're proud of and what we'd like to change given the opportunity.
Yeah, I see tea room conversation as just the biggest space of cultural compression. Like, if you want to know about what the culture in a workplace is like, and there's enough staff gathered in a tea room at any given time, you, as an anthropologist sitting in a corner, you'll pick up what the prevailing culture and the feel of that is quite quickly. And I think you can notice the difference in when multiple people are coming together with a shared understanding and discussing it, and you go, actually, that's really productive and that is really accurate, especially when you're hearing people that weren't actually involved in the event retelling it and discussing, I heard from such and such about this the other day, those retell stories, and it's as accurate as your impression was of what actually happened at the time. that's when you know a good debrief's happened.
Right. So I'm going to try and summarize our debunking debriefing myths. So number one was debriefs can cause harm. And we're not saying they can't ever, but on the whole, the work's already occurred, then the chatter is already happening, and the Cochrane Review, which continues to be the number one resource that people go back to, even though it was published in 2010, and the hundreds of articles that have subsequently been published saying how important debriefing is, continues to prevail. So on the whole, debriefing does not cause harm. Number two, debriefs can only happen after critical events. And what we're really trying to promote here is that debriefing to learn can happen anywhere for any group, anytime. It can happen in an outpatient's setting. It can happen with the mundane, the novel, the interesting, the outstanding, the terrible, the confronting. It can, and I guess the other big thing about this is that when you're thinking about debriefing to learn, it can happen in any environment at any time. Number three, debriefs should be psychologically based. We have repeatedly said during this podcast that that is actually incorrect and can be very harmful, that really we want to bring the focus to debriefing back to a same shared mental model and the opportunity to learn and grow. Number four, you can't lead a debrief if you are involved. There might be occasions, very rarely, where this is true, but on the whole, you want people who were actually there, who saw the way that things unfolded, who have expertise in the subject matter, in the team dynamics, in the patient. So we want to recognizing that, like any part of leadership, none of us should just wander on in and have a crack at it. Facilitating a debrief takes skill and it takes some insight and awareness into yourself. But whoever is leading a debrief is not pontificating, is not coming in with judgment. They're facilitating the whole group coming together and talking about their shared experience. And number five is we don't have any time to debrief. And I guess the point we're trying to make is you don't have time not to debrief. That people will debrief, people will go off in their various disciplines and try to make sense of this. And if I'm a junior nurse working in anaesthetics in theatres and it's my third shift, the sense that I'm going to make an event can be harmful, incorrect, and I can place a lot of blame on myself. So what we want to do is be in a room with the people who are involved and the expertise so that we can work out what was fiction and what was fact. Jessie, thank you so much for joining us today on 5 Things.
Thanks, Liz. My pleasure. And thank you for joining us too. The Royal Brisbane and Women's Hospital 5 Things Nursing podcast acknowledges the Turrbal and Yagara as the First Nations owners of the lands we now tread. We pay respect to their elders, laws, customs and creation spirits. We recognise that these lands have always been places of healing, teaching and learning. We also wish to acknowledge the First Nations people of the lands of our global community and encourage our listeners to seek out, listen and learn from the knowledge held in your shared space. As well as all major podcast outlets, you can find us at 5thingsnursing.podbean.com. Please also subscribe and give us a rating on your listening platform of choice. This helps others find the podcast. And finally, if you'd like to connect with Liz or myself on Twitter, we can be found at LizCrow2, and for me, it's inject_orange. We would absolutely love to hear your thoughts, ideas, or feedback. Thanks for listening to 5 Things.